Hello and welcome to this webinar entitled COVID-Coag, a conversation about the controversies and confusion. Our moderator is Mr. George A. Fritzma. Mr. Fritzma holds a master's in medical laboratory science from Wayne State University and advanced coursework from the University of Illinois at Chicago. He consults for the Laboratory Medicine Division of the University of Alabama Hospital and teaches online for Michigan State and Rutgers universities. George is a contributing author for Rodax Hematology, published in 2019, and is a scientific advisor for Biomedica Diagnostics, Inc. He manages the Fritzma Factor, your interactive hemostasis resource, at fritzmafactor.com. He'll be sharing his own insights and that of his esteemed guest to help you better understand the connection between hemostasis and severe COVID-19. Now I'll pass it on to Mr. Fritzma.
Thank you, Rose, for that introduction. And good afternoon or good day, everybody. It's now my pleasure to introduce today's presenter, Dr. Andrew Goodwin. He is Director of Clinical Laboratory Science and Clinical Laboratory Medicine at the University of Vermont Medical Center in Burlington. Dr. Goodwin is an expert on thrombosis risk in cancer, pre-analytical variables, and the D-dimer assay, and has served as Vice Chair of the CAP Hemostasis and Thrombosis Committee. He is also the Deputy Regional Commissioner for the Northeast region of the CAP Laboratory Accreditation Program. Today's discussion focuses on hemostasis and inflammatory markers related to COVID progression. Dr. Goodwin will give a brief overview. This will be followed by a dialogue between Dr. Goodwin and me. And as Rose explained, participants are invited to ask questions through the Q&A access. I'll now turn the discussion over to Dr. Goodwin for his introduction to today's material.
George, thank you very much. I'm very happy to be here, and I really appreciate the opportunity to discuss what has rapidly become some big controversies and confusions when we're discussing COVID-associated coagulopathy. I think it's important that we understand what we're going to cover today. So we're going to discuss the pathophysiology and comorbidities associated with COVID infections. And we're going to apply some relevant COVID diagnostic and prognostic laboratory assay results. At that point, hopefully we'll be able to align some of the COVID lab results that we've discussed, the pathophysiology, and whether or not they have any impact in disease diagnosis and disease progression. You've heard already that the format today is going to be a brief introduction followed by a dialogue of question and answers between myself and George. And there are resources available to help meet today's objectives. So before we get started, I think it's really important that we all understand the nomenclature that's been used when we talk about SARS or COVID or novel coronavirus. So SARS, an acronym for severe acute respiratory virus 2, or COVID, which is the coronavirus disease of 2019, or the novel coronavirus. Now, for many of us on this phone call, it might seem that this pandemic has been going on for a very, very long time, when in actuality, it was only declared an international pandemic by the World Health Organization approximately 6 months ago. Now, that doesn't mean that we weren't learning about this disease earlier than that, with the infections coming out of Wuhan, China, as they were being reported back in December. But officially, this pandemic has only been in place for approximately 6 months. So what is the COVID-19 virus? Well, it presents as a respiratory-like illness in a minority of patients. It's in all actuality, a majority of the patients that are infected by COVID-19 are asymptomatic and might not know they ever had been infected. As we all know, it's spread through aerosolization of droplets or contact with contaminated surfaces. The virus then is introduced into the human via mouth, nose, or eye mucosal membranes. The most sensitive and sort of the diagnostic gold standard that we have available to us today in the laboratory is reverse transcriptase PCR. And the virus itself is an RNA virus. That RNA virus contains a lipid bilayer which hosts a series of a significant number of proteins. Some of these proteins, as depicted in the cartoon in the lower right-hand corner here, are either envelope proteins in the orange or the membrane proteins. But what's most notable and what most of us recognize when we see images such as this are these red proteins, these so-called spike proteins that are coming off of the virus. This is what gives the name coronavirus, corona meaning crown-like, and you can actually see these on the EM electron microscopy here. So COVID-associated coagulopathies, they are a relatively high incidence of thrombotic events that occur in COVID-infected individuals. Most notable, though, it's being identified or being experienced in those patients that are sick enough to be admitted to the ICU, usually due to respiratory compromise, as diagnosed by acute respiratory distress syndrome or an associated bronchopneumonia. Now, the coagulopathy that's being reported is wide in its presentation. We're seeing coagulopathies involving the venous and arterial circulations. In the venous circulation, we're seeing the usual deep vein thrombosis, but we're seeing some unusual presentations as well: splenic veins, cerebral sinus veins, and then also the in situ pulmonary artery. In the arterial side, we're seeing a higher incidence in the cerebral, coronary, and limb arterial circulation. Of course, that results in cerebral vascular accidents, myocardial ischemic events, and limb ischemic events as well if it's in the extremities. And venous thromboembolic disease and pulmonary emboli are also being reported in patients that develop a coagulopathy associated with COVID. I think the pathophysiology is what's really important to understand here. And I think it's been, a while since we've thought long and hard about sepsis and its relationship to coagulopathy. And when we think about sepsis and coagulopathy, patients that are septic can have activation of the coagulation system. And the amount of coagulation of activation can be controlled by a couple of different variables in the sepsis, including the degree of sepsis, the burden, if you will, or even in some cases, the length of which a patient remains septic. What we do know is mortality increases with the severity of the coagulopathy that's associated with sepsis. And in patients that develop a coagulopathy in the background of a septic illness, we term that septic-induced coagulopathy, and this can result in disseminated intravascular coagulation. So this is a cartoon that has been published in the literature. There's variations of this cartoon available, and I think it's a very nice overview of the relationship between coagulation and sepsis. And what we know is there are multiple factors that activate coagulation during sepsis. So in sepsis, the immune cells, such as monocyte macrophages, are activated by something called pathogen-associated molecular patterns, or the host-derived response, the host-derived damage-associated molecular patterns. Examples of these would include cell-free DNA or even histones associated with DNA. When released from damaged tissues and damaged cells, they can initiate inflammation and the associated coagulopathy. Now, we know tissue factor is a critical initiator of the extrinsic coagulation pathway and is expressed on monocyte macrophages and on endothelial cells and plays a central role in the development of coagulopathy and DIC, particularly DIC that arises out of sepsis. So following cellular injury, tissue factor is expressed on the surface of monocyte macrophages and in extracellular vesicles and can further promote coagulation. Additional humoral mediators are responsible for coagulopathy as well, and these are the sort of pro-inflammatory cytokines. Those would include interleukin-1, interleukin-6, and tissue necrosis factor, as well as potential dysregulation of the complement system. It is through this cytokine release that you get additional activation of the coagulation system in a procoagulant fashion, but it's also believed that they might have some anticoagulant properties such as disruption of the activated protein C pathway or even some impaired fibrinolysis. Finally, we have the so-called neutrophil extracellular traps. Neutrophil extracellular traps consist of DNA, histones, granule proteins that are released from activated neutrophils in response to, or actually, and cell death of neutrophils in response to the infection that's going on. Research has demonstrated that the interaction between these nets and extracellular vesicles, the so-called net-bearing extracellular vesicle, can actually increase thrombin generation and ultimately result in additional thrombus formation through fibrin conversion. So in summary, all of these inflammatory mediators, whether it be the so-called DAMPs and PAMPs that activate monocyte macrophages, whether it be the neutrophil extracellular traps, all of these can result in additional thrombus formation. There was a really nice commentary that was published in the, I believe it was the April issue of JTH, Journal of Thrombosis and Hemostasis. Dr. Connors wrote a very nice commentary reminding us of these interactions that occur in the term thromboinflammation. And I think that's a great, that's a really good description in understanding the relationship between coagulation and arising in sepsis, this so-called thromboinflammation. So how does all of this progress to DIC? Well, we know that there are three factors that contribute to DIC, and that includes coagulation activation, endothelial cell damage, and platelet aggregation. So as we've already discussed, tissue factors expressed on leukocytes, monocyte macrophages, as well as a phospholipid-rich surface with the phosphatidylserines on the damaged cell, and that can activate coagulation. It can decrease anticoagulant systems and accelerate clot formation, and we can also see the platelet aggregation. Endothelial cell damage reduces the antithrombotic mechanisms, often associated with the loss of the glycocalyx and the reduction of the activated protein C pathway, and again, perhaps impaired fibrinolysis. So before we discuss really the picture of DIC that can arise in a patient with sepsis, we have to understand what that definition means. And as we know, ISTH has defined DIC as an acquired syndrome characterized by intravascular activation of coagulation with loss of localization arising from different causes that it originates from and causes damage to the microvasculature, which, if sufficiently severe, can produce organ dysfunction. So that is DIC. But what we're recognizing is that evidence is demonstrating that septic patients can develop a coagulopathy as well. And it actually is critical that we identify these septic patients that are developing a coagulopathy and consider targeting them for anticoagulant therapy. So therefore, we have really a category, which is an earlier phase of DIC that is being termed as SIC, or sepsis-induced coagulopathy. This is a nice illustration of the time course and severity that can lead from infection all the way through SIC to DIC. So sepsis-induced coagulopathy can produce to DIC if the infection or inflammation is severe enough, and the inflammation being the host response. Transient activation of the fibrinolysis through TPA release can allow for fibrinolysis to occur, but you can also have increased production of the plasminogen activator inhibitor 1, or PI1, which can subsequently suppress fibrinolysis. And it's this imbalance between coagulation and fibrinolysis that can lead to the hypercoagulable state in organ dysfunction in patients that develop DIC out of sepsis. There are scores available. As you know, this was the revised ISTH scoring system for DIC and SIC. The variables that feed into these scoring systems include platelet count, D-dimer for patients with DIC, prothrombin time, so a PT ratio rather than the INR. It really is the prothrombin time that we have to focus on. And of course, fibrinogen as well is important in patients with DIC. There's also the SOFA score, SOFA meaning the sequential organ failure assessment that feeds into the SIC scoring system. And that SOFA score is a separate scoring system that evaluates respiratory, cardiovascular, hepatic, and renal abnormalities. So to summarize yet again, we're talking about an infection that begins, an infection that is significant enough, that is severe enough, and that results in an inflammatory response from the host. and results in some of these in the mononuclear cell activation, the tissue factor that I've described, the pro-inflammatory cytokines. And then as we move through the process, depending on which of these factors contribute to the overall picture, you can develop either patients that have intravascular fibrin formation. You can have patients that have decreased fibrinolysis that, of course, will accentuate the fibrin formation or the thrombus, or you can actually have consumption of the coagulation factors, impaired platelet function, and we can lead to the bleeding phenotype that we often associate patients with DIC. Clinically, how does the coagulation sepsis, how does it present itself? Well, we have a hyperfibrinolytic component, or the so-called bleeding type. I think that's what most clinicians associate with when they think about DIC. And again, the bleeding type is often seen in the acute leukemic patients, the obstetric complications, or associated with trauma. We have the hypofibrinolytic component, the so-called coagulation component of DIC. And this is often resulting in end organ damage. And this is seen in patients who develop DIC in association with a septic picture. We have the asymptomatic component as well, George. The asymptomatic component can be, the laboratory values suggest that a patient might be in DIC, but they're not presenting with any symptoms. And then if they go through a significant enough consumptive phase, they present with a massive bleeding phenotype. So in COVID coagulopathy, the COVID-19 coagulopathy, there's a few things that we're identifying. We're identifying that these patients don't have that typical sepsis-related DIC picture. We're not seeing the prominent thrombocytopenia that we typically think about. We're not seeing the significant consumption of coagulation proteins. We're seeing while we're seeing an elevated D-dimer, we're also seeing high fibrinogen as well. There have been autopsy publications presented in the literature looking at the lung findings in patients initially out of Wuhan, China, that showed fibrin deposition and fibrin platelet microthrombi in the pulmonary vasculature. So we are seeing evidence of intravascular thrombi in these patients. But we're also seeing intraalveolar fibrin deposition. So that's extravascular in its presentation. And this is most often in patients with the acute respiratory distress syndrome. And bleeding, again, does not seem to be one of the key features that we're seeing, but rather more of these thrombotic events. Just to give a full picture of some of the pathophysiology that we're seeing this year, these are histologic sections taken from one of those autopsies in Wuhan, China that was presented. And what we're seeing here in panel A is this is a section from from the left lung or right lung, I honestly don't remember, but from one of the lungs in this patient. These are the air spaces, the alveolar air spaces. And what we're seeing is that some of the pneumocytes are actually starting to fall off or going through desquamation, falling off of the alveolar lining. And these cells are showing these multinucleated features right here, which is indicative of virocytopathic change. We're seeing this amorphic pink material, which is hyaline membrane formation. So this is indicative of early acute respiratory distress syndrome. If we move on to panel B, in a different section of lung, again, we're seeing these type 2 pneumocytes that are being desquamated and showing viropathic change. And now we're starting to see some fibrin deposition, mononuclear cell inflammation in the alveolar spaces as well. So it's sort of the end of the introduction here, George. Before we get into the discussion, I just want to, indicate some of the earlier studies that were being published, or earlier information, I should say, that's being published, is that we are seeing an increased incidence in leg DVT in patients in the ICU, and in those patients with a COVID coagulopathy. And what was initially reported is these patients tend to be of older age. They had prolonged PTTs and higher D-dimers compared to those who did not develop VTE. And a study out of the Netherlands in severely ill ICU patients also showed a pretty high rate of thrombosis in patients, and they were showing a higher incidence of both PT and PTT in these patients. So George, that's just the brief introduction, really focused mainly on sepsis and coagulopathy and the relationship that we're learning in these patients.
Thank you very much, Dr. Goodwin. That was a really terrific overview. Let's start with talking about the D-dimer. Everywhere I look, people are saying that they're having high volumes of D-dimers being ordered these days. So would you say the D-dimer is the best assay that we can use? Are there other assays that help along with that? And while I'm asking the question, already in the Q&A section, someone has asked if we need to do the FDPs along with the D-dimer.
Yeah, sure. So I'm going to go back and share my screen. Give me 1 second here, George. Okay. So share screen. One thing I'm learning in all of this COVID pandemic is how to navigate multiple systems here. Okay, so COVID-associated coagulopathy, yes, we are seeing that a marked increase in the number of D-dimers that are being ordered. And there are other laboratory values that are being reported as elevated in patients with the SARS-CoV-2 infection. So this was a study that came back in the springtime. And what we identified is they were showing laboratory values in patients that had COVID coagulopathy versus controls. And what they identified is the statistically significant differences were in the antithrombin, the D-dimer, fibrin degradation products, and fibrinogen levels. And what you see here is that compared to controls, antithrombin was lower. D-dimer was really markedly elevated compared to a control. Fibrin degradation products, again, elevated as well. And the fibrinogen elevated compared to control. They further looked at, let me just pull this forward here. They further looked at then severity as well. And what was interesting is that D-dimer and fibrin degradation products really stood out in looking at the severity of the disease. You can see here in the severe and critical patients, the D-dimer and FDPs were elevated relative to the so-called ordinary group of patients who were infected with SARS-CoV-2. So to answer the question, D-dimer, I think, is definitely indicative of a patient that has a coagulopathy associated with COVID, particularly elevated in those that are severe. I also believe that antithrombin is helpful in some scenarios compared to controls. And fibrinogen is definitely elevated as well compared to non-COVID patients. To address whether or not an FDP is needed in addition to the D-dimer, most of the literature I have seen that there is a relationship between FDPs and D-dimer. So I think D-dimer is a reasonable analyte to evaluate in these patients. Multiple reports have shown that D-dimer is higher, and again, it's in the patients that have more progression of disease all the way to the acute respiratory distress, or even those that were non-survivors of their COVID disease. In a meta-analysis of 779 patients, 22% of them with severe disease, their platelet count was below the normal reference range, so that was in patients with severe disease. So even though we haven't seen thrombocytopenias in all comers with COVID coagulopathy, if you do see a platelet count that is below the normal reference range, that is potentially indicative of severe disease. In looking at patients that were admitted for novel corona pneumonia on admission to the ICU, some analytes stood out as well. I've already talked about the D-dimer, George, as well as FDP. Those remain clinically significant when you look at survivors versus non-survivors. One of the other assays that showed prolongation is the prothrombin time. It was statistically significant in discerning between those that were survivors versus non-survivors. So now we're talking about fibrinogen, D-dimer, potentially a platelet count, and a prothrombin time. In looking at, from that same study, and looking at 21 of the patients that were the non-survivors, 71% of them actually met the criteria for DIC. So you can see there's, these are all the criteria here, George, for the list, for the score system for DIC. Things that stand out to me anyway is that patients were showing a prolongation of the PT. But D-dimer, again, really was, in 18 of the 21 patients that were non-survivors had an elevated D-dimer. So it's not going to help you discern between survivor and non-survivor, but certainly it looks like it might help you in patients, in all comers. And then in the survivor group, only 6.6% of those patients met the true criteria for DIC. Now this next image I'm going to show is a little bit busy, and I apologize, and I'm hopeful that everybody can see this graph or this image nicely. But what I'm going to do is walk you through it. And what it is it's showing you laboratory values based on survivors, non-survivors being the green lines versus the survivors. And if you look at all the different analytes, PT, PTT, D-dimer, FDPs, fibrinogen, antithrombin, similar to what we've already discussed, over time, non-survivors, the prothrombin time prolongs relative to the non-survivors. PTT also showed some significance, but not to me quite as striking, with a little bit of overlap. D-dimer, definitely, again, showing patients who were non-survivors, their D-dimer was elevated and remained elevated, but didn't increase to the level of the non-survivors, again, in the green. Same with the FDPs. So I think there's really good relationship between those two, and I believe D-dimer is a good analyte, not needing FDP. Fibrinogen, George, fibrinogen here, you can see that the fibrinogen is elevated early on in the disease for both survivors and non-survivors, but at the late stage, the non-survivor fibrinogen drops off, and this might be those patients that are truly entering into the DIC in a consumptive process. And antithrombin, again, showing some difference later on in the disease process. I have had some discussions with folks around the country, around the US, I should say, regarding viscoelastic assays. TEG is one of those viscoelastic measurements. There's been some studies that have been published. This was looking at 24 ICU patients, some of which had more than one evaluation via a viscoelastic assay. And as one might expect, given the fibrinogen, the high fibrinogen in these patients, the maximum amplitude, which indicates clot strength, is elevated in these patients. 83% of the time it was showing a clot strength above the upper limit of normal. And interestingly, even though these patients have elevated D-dimers, the viscoelastic measurement for lysis, the LY30, is not elevated in very many of the patients. Not many of them have elevated or increased lytic activity as identified by viscoelastic assay. So that's kind of an interesting finding, I would say. So in summary, George, PT, PTT are prolonged slightly. The platelet count was normal in the early stages of patients with COVID coagulopathy, but did show with progression of disease in severe patients, they became thrombocytopenic. Fibrinogen was increased, D-dimer is increased. And patients with severe COVID infections develop coagulation, resulting in microthrombotic events, seeing a lot in the lungs. D-dimer and low platelets is associated with severe disease. D-dimer in a prolonged PT or PTT is a risk for thrombotic events. And I think it's early, but the TEG, again, showing some hypercoagulable, but certainly not showing any of the lytic activity. Long answer, George, sorry.
That's quite all right. Very good, very interesting. And it raises the question, really, when you are measuring D-dimer, are you really measuring for DIC or fibrinolysis? But before I get to that question, would you please this is a question that came up already in our Q&A column, just comment on the reporting units for D-dimer. And I know this is a core subject that you spent a lot of time on, but just a brief comment.
No, absolutely, George. Yeah, the D-dimer unit and magnitude and unit of measure is sort of the gift that keeps on giving to those of us who deal with the laboratory coagulation parameters. I think it's critically important, whether you're reading literature on COVID coagulopathy or anything, that you understand what's being reported. As we know, D-dimer is reported in DDUs or FEUs, D-dimer units, or FEUs, the fibrinogen equivalent. I'm confident that most folks recognize that there's a relationship between those two, where one DDU is equal to 2 FEUs. So a DDU of 250 is going to be an FEU of 500. And so as the literature is reporting, not only the diagnostic criteria, whether it be COVID coagulopathy or any other disease, or whether or not you're using it for rule out, whether or not you're using it to initiate therapy in COVID coagulopathy, which is one of the things that's being debated in the literature, it's critically important to understand what's being measured. DDU and FEU are not the same. I think most of the literature is reporting in FEUs, George. That would be my assumption from reading through, but it's really important. You are absolutely correct.
Yeah. Well, I just know that that's kind of a tough subject, and
it is a tough subject. It really is.
Can't seem to ever reach harmonization on those.
No, harmonization would be very welcomed in this scenario. Yes,
really would. Yeah, it would
Yep.
be helpful. Anyway, so moving on though, still the D-dimer leads us to talking about the mechanism, which could be DIC, could be something to do with the fibrinolytic mechanism. And I just wonder, A, which is it, and B, how do you go about determining what's going on?
Sure, exactly. So let me, oops, here we go. Andy's got to get back to presenting the screen here, George. Screen share. Okay. So again, I've already presented this slide, and I'm not going to spend any more time on it, but we're talking about how do you identify DIC, and is there a difference between DIC and SIC, or sepsis-induced coagulopathy? And certainly there are scoring systems that are out there that indicate that there is a difference, and guidelines and discussions, particularly in this COVID era, are talking about identifying those patients in SIC and targeting them for therapy earlier on in the process. We are understanding that in sepsis-related coagulopathies, you can start with that infection, progress through SIC, and ultimately to DIC. And depending on where in the spectrum a patient is, they could have a thrombotic or fibrinolytic phenotype associated with their underlying cause for an abnormal coagulation. So one of the things that you brought up, George, was, fibrinolysis, and are we actually, is this DIC that we are seeing in COVID patients? And certainly there is commentaries in the literature that say this is all form of DIC. And there are other commentaries or other opinions that this is, again, SIC potentially evolving into a true DIC picture. So if we think of fibrinolysis as one of the criteria, which again is in the ISTH guidelines for DIC, what do we have available to us? Well, most of us in laboratory medicine recognize that evaluating fibrinolysis is a challenge. Certainly the TEG or the ROTEM, the two viscoelastic assays, are visual indicators of potential lysis. I'm just going to focus on the TEG for this presentation, George. But the TEG has, as we all know, is a whole blood assay, and it can look not only at clot strength and sort of the procoagulant aspect of the coag system, but it can also look at clot stability and whether or not lytic activity occurs. And what we understand is in true DIC, we see sort of an early hypercoagulable state indicated by often a short R, an increased angle, and an elevated maximum amplitude. But then as we start to see the DIC component or the lytic aspect of it, fibrinolysis, we start to see the tail of the graph move back towards the middle, and then ultimately you get to the hypocoagulable state, which is consumption of factors. And there are case reports in literature to suggest that this is actually going on. This is a case report that was published showing a patient who had early DIC, was treated with unfractionated heparin, and you can see from, this is pre-heparin therapy, post-heparin therapy, it did resolve the lytic activity in this patient. So how is it, George, that we're going to evaluate the fibrinolytic system? Right now, TEG is one, viscoelastic assays is one of those mechanisms in which we can do that. I think a question, George, though, is, and I'd love to hear your opinion on it, is what's going on if we're seeing these elevated D dimers, but we're not seeing in all patients fibrinolysis? How are we getting there? I'm curious. Do you have any thoughts or insight into that? I have a few, but I'd be curious if you've given it some thought.
It would seem as though what we're seeing perhaps is sort of if this is something you've seen as sort of a organ-specific DIC or
Mm-hmm.
localized DIC where it's happening in one particular location.
Mm-hmm.
And there does seem to be, what you have already shown, the component of hypocoagulability, hypofibrinolysis along
Mm-hmm.
with that. So
Mm-hmm.
could that be close?
Well, I mean, I think we're early in this process, George. So I think anybody can offer an opinion here, and I agree with you. I think that there is some organ specificity to this, and there has been some published literature on this as well. One of the things that we're seeing is that I showed you this panel already, but is there a potential that there is we know there's extra vascular fibrin formation in the lung spaces of patients with severe acute respiratory distress syndrome? And could we be seeing the fibrinolysis? Could the D-dimer be a pulmonary source, in other words, of coming from a patient that has acute respiratory distress syndrome? And I think the other thing that is important is we're starting to recognize that there's true vascular damage by SARS-CoV-2. And one of the things that happens when the virus infects the vascular endothelium is when it causes damage, you get release of Pi1. And so we could, if I go back, I'm just going to go back a few slides. Sorry about this. I don't mean to make anybody ill here. Oops, there it is. But is it possible that what we're seeing is either Pi1 production or a release of Pi1 from damaged vascular endothelium due to direct infection by COVID itself? So those are the two mechanisms that I think people are entertaining right now as the source of seeing D-dimer being elevated even with the lack of fibrinolysis by some of our laboratory assays.
Good. Well, thanks for that answer. That's excellent. Kind of shifting gears a little bit, going back to the platelets that you had illustrated, particularly in the sepsis model that you showed. So it seems as though platelets are sort of at the middle of all of this. And is there anything we can do about platelet measurement or measurement of the of some of the other inflammatory or sepsis markers that'll be helpful? And then while I'm talking about that, I've heard that there's a higher prevalence of HIT in COVID. So I'm wondering, if the platelets are somehow involved in that.
Sure.
Seems like they would be, but.
Yeah. I mean, and I would agree. And I would say that, regarding the HIT discussion, and we can talk about it shortly. I would say even anecdotally here at UVM, I was describing to you, George, that we saw early on, sort of before COVID became sort of the international pandemic, we were seeing increased patients with HIT in our ICU, and these were patients that had respiratory illnesses. And sort of in retrospect, we've discussed at some of our meetings whether or not these patients actually had COVID and as they were being treated with heparin, developed HIT, and it just was unrecognized to us at that point. So yes, let's discuss that a little further. So what I need to do is go back and share my screen. So if I remember correctly, your first question was about any sort of platelet involvement, and what's the role in platelets with all of this? So again, what I didn't discuss is, or what I did discuss, I should say, is the coagulation, sepsis, and platelet activation. What I didn't discuss is there's additional thoughts around is the COVID-associated coagulopathy some form of a thrombotic microangiopathy? Is this some evidence of their TTP or even a hemolytic uremic syndrome? Is there some component to that? And so there have been some early indications that platelet activation is certainly important in all of this. We are identifying that the MA, again, is not only driven by fibrinogen, but driven by platelet activation as well. And because we're seeing this elevated MA in patients with COVID coagulopathy, it does lend itself to the discussion that we are seeing platelet activation in these patients. Let me go back, sorry. So I think it's important that we do consider that these patients might have some form of thrombotic microangiopathy. Remember, when Adams TS13 it has been reported to be lower in some of these patients. Now, the range of reported Adam TS13, again, we know that's the metalloprotease is responsible for cleaving the ultra-large molecular weight fragments of von Willebrands. We are seeing in some patients that those values, the Adam TS13 values are dropping into the 40% range. And I saw even one study one case report that reported the patient had an Adam TS13 around 10%, George. So maybe there's a component to a thrombotic microangiopathy that is going on here. And of course, that is going to lead to platelet aggregation in patients with a TMA. And then the other one is dysregulated, the dysregulated complement system. Certainly the dysregulated complement system, often associated with hemolytic uremic syndrome, is another area in which we need to further investigate whether or not there's a component to this in the patients with COVID coagulopathy. What I will say, though, is in the tissue, the TMAs that are being considered, we're not seeing marked increase in schistocytes. I mean, if we think about the diagnosis of TMAs, right? We think about LDH, we think about schistocytes, we think about reduced platelet counts, markedly reduced platelet counts, and certainly in TTP, we think about Adam TS13. The platelet counts aren't markedly reduced in the usual or the non-severe COVID coagulopathy. The schistocytes aren't markedly elevated, if present at all. Adams TS13 is variable in what we're seeing as far as reported values, so hard to know for sure. You asked me about HIT, right?
Yeah.
Okay.
Yeah.
Sort of, and a good segue, because I think HIT, as we know, HIT, heparin-induced thrombocytopenia, these patients, the typical HIT patient exposed to heparin, often a specific cohort of patients, or more often associated with specific cohorts of patients, the surgical patients, for example. Exposure to unfractionated heparin is the highest risk. Trauma, again, which is a form of surgery. And then, of course, the duration. All of those feed into whether or not a patient develops HIT. So what has been reported thus far is a couple of studies, a couple of reports, including this one, which I thought was quite interesting, by Patel and colleagues. And what they did is they looked at 439 hospitalized patients with COVID-19, and 88 of those patients actually received unfractionated heparin therapy for at least 5 days. Okay, so in that 88, 58 of them had a COVID coagulopathy, 15 were on it for presumed or confirmed thrombosis, and another 15 on for AFib. In these patients, 8 of the patients suspected of having HIT, 5 of them tested positive by latex immunoassay. So they further reported that a cumulative incidence of HIT was around 12% at 25 days. And they compared that to the non-COVID hospitalized cohort that received heparin, where the HIT rate was less than 3%. We've seen HIT rates in patients receiving heparin, as low as less than 0.1%. So 12% is a pretty significant increase in patients with HIT. So this result really does suggest a higher incidence of HIT in patients being treated with unfractionated heparin therapy. I mean, I think there's a real difference here, right? It's important when looking through this literature to identify what patients are being treated with, because we know from publications and risk that unfractionated heparin therapy carries the highest risk.
Right.
Workington and colleagues, publishes so much on HIT, and what, aside from all the variables that impact the presence of HIT, they were cautious. They were cautious in overdiagnosing patients with HIT at this early stage, and really that there needs to be some more investigation into these patients that develop, a thrombocytopenia, particularly when they get down, less than 100,000 down into the 50,000 range. It can be hard to identify these patients, George, because they can have a COVID coagulopathy patient can have a thrombocytosis. And when we think about the 4T score, we always think about the absolute number when in fact less than 50 or a 50% reduction is also one of those criteria. So it really behooves the clinical teams and the laboratorians to pay close attention to these patients who have COVID with a thrombosis receiving heparin therapy. And really their recommendation from Workington and his group was that if you have a patient that you have a high suspicion for HIT, that additional platelet function assays, the functional platelet activation assays might be really important here, particularly in those with high pretest probabilities, and even consider some of the newer PF4 dependent platelet activation assays or the P-selectin expression assay that's available out there. And I encourage participants to look at that paper because they also showed a significant overlap in some of the features for COVID-19 versus HIT. You can see there's quite a few similarities, including frequency of thrombosis, venous versus arterial thrombosis. There are some similarities and some differences, and this is a really nice summary table to help people navigate through that evaluation.
Great, that's very interesting. And I particularly like the brief discussion you went into TMA, thrombotic microangiopathy, because it seems like I know there's an ADAM-TS13 concentrate that's being used, and
sure.
It's interesting to think of how that might intervene somehow in,
right.
In COVID.
Well, and I think another question that's kind of interesting, George, is if ADAMS-TS13 is playing a role, particularly if there's, likely there's overlap in all of these. COVID is going to be sort of at the center, and is it going to be a coagulopathy DIC? Is it going to be a tissue microangiopathy that's resulting in the significant disease that we're seeing in these patients? But when it comes to ADAMS-TS13, this is an inflammatory response. So is this an antibody? Is this an acquired antibody that's removing ADAM-TS13, or is this a reduction in production of ADAM-TS13 in a severely ill patient?
Yeah.
And so I think it's going to be, particularly when it comes to therapy, it's going to be interesting if we do get a concentrate, how patients respond to even the concentrate. It might shed some light on the true pathophysiology behind all of this as well.
Yeah, great. There are a couple of other questions that I had to ask, but I think let's go to the Q&A. We've gotten a number of questions from folks. I've covered 2 or 3 of these already, a couple of them from Dave McGlasson, who has some things he's talked about before. He does want to comment on that SIC score that's using the prothrombin time ratio rather than prothrombin time in seconds.
Yeah, please.
Yeah, he feels that's a criticism.
He feels it's a criticism, as opposed. Okay, and so that as opposed to using just the straight prothrombin.
Yeah, straight prothrombin time in seconds.
Yeah.
One thing I've heard, I'll just interject real quick.
Please do.
The prothrombin time in seconds, unfortunately, is procedure dependent and can vary from place to place. So it's a little harder to harmonize those results.
And I would agree with that. And that's why my understanding of using the prothrombin time ratio is really taking what, as you just said, the relationship of a local reagent instrument combination, and then evaluating that patient result relative to your locally established norm versus using a straight prothrombin time in seconds, which, like you said, can vary. So the ratio is perhaps is better evaluating your patient on your platform with your reagent pack. And I definitely think it's better to use the ratio than it would be to use the INR. I don't think the INR would be the appropriate use here in patients that you're evaluating for DIC.
Good.
Although everybody does.
Yeah, that's true.
Everybody does, right?
Here's a question from Heather DeVries in Indiana. She says, this is more of a comment than a question. Indiana University Health West and Avon saw an increase in emergency department requests for fibrinogen levels that has seemed to have leveled off. Are the findings of increased fibrinogen levels not clinically significant in these patients?
So, I think that we saw an marked increase in D-dimer, which has leveled off over the summer months, and we also saw fibrinogen levels. The fibrinogen didn't go up quite as much. I don't know what the reason behind that would be. I do believe that it's important to evaluate the D-dimer and the fibrinogen levels, because as we know, D-dimer is not specific to fibrinolysis. So I think in patients with respiratory-like illnesses, measuring fibrinogen, measuring D-dimer, doing the complement of tests is really helpful. And I also think that it's important that it was shown that in that one picture that I showed, that the the fibrinogen in later stage disease for those that are quite ill, the severely ill and the non-survivors, those patients actually showed a drop in their fibrinogen level. So I think, yeah, here it is. I think it's important that we continue to actually evaluate these laboratory assays, not only for identification and diagnosis, but also perhaps for progression for disease. So this was the figure I was referring to, George, here. Here fibrinogen is elevated both in survivors and non-survivors, but clearly in the non-survivor group, the fibrinogen does drop off markedly, and it's used in the score system for DIC. So I appreciate the question from Indiana, and I would recommend that we still evaluate fibrinogen.
Keep that slide up for a moment too.
Okay.
I think do you have antithrombin on that slide?
I do. Yep, hold on. Sorry, so many buttons.
There you go. No,
there it is. Yes.
Okay, good. And I was looking at the antithrombin levels. Donna Castellone had reported to me that they were getting a lot of antithrombin orders where she is, and she also asks about protein C and protein S. Do those go down as well as antithrombin?
So there has been some literature published to show that protein C in particular, protein S I would assume would go in the same direction, and we have to remember that protein S is also dependent on the so-called type 3 protein S because of its binding to C4b binding protein. I think it can be a challenge, but certainly for protein C has been reported to decrease. Antithrombin has been reported to decrease, and I'm curious if the use of antithrombin, the orders for antithrombin coming in that Donna reported, was for diagnostic or for therapeutic in so-called heparin resistance. If patients are being treated with unfractionated heparin, and this is a whole nother discussion, if they're being treated with heparin, which heparin do you use, low molecular weight or unfractionated? And if you're using unfractionated, how do you monitor the unfractionated heparin? I think, smaller laboratories might not have the ability to do the anti-10A methodology for monitoring heparin, and maybe using PTT to target the therapeutic level. Something to consider in these patients, certainly want to get a baseline PTT before you start, to make sure that the baseline PTT would be normal before you'd use it for monitoring therapeutic levels. If a laboratory is monitoring heparin using anti-10A assays, there are two platforms on the market. You can either add exogenous antithrombin or not. In our laboratory, I'll tell you, we do not use exogenous antithrombin for the sole purpose of trying to identify those patients that might be heparin resistant due to antithrombin deficiency.
Yeah.
So for Donna's question, I think that it is lower in patients with COVID coagulopathy, but it also could feed into how they're being treated and whether or not they would need replacement for full efficacy of the unfractionated heparin.
Good, thank you. We got a question from Rebecca Carter, and this goes to the inflammatory markers. Can you comment on the results reported last week in JAMA compared to patients with septic shock and ARDS? The COVID-19 cohort has lower levels of tumor necrosis factor, IL-6 and IL-8. The differences were statistically significant for the tumor, for all three, apparently, yes. So yeah, I know Rebecca's interests are into inflammation, so that's what she's asking about.
Yeah, so I'll be honest. In full disclosure, I did not review that article, and so I apologize in advance that I can't answer your question. And George, maybe you could answer the question. But my understanding is that in these patients, we are seeing elevated levels of IL-6, for example, and those have actually been in concert with patients having elevated fibrinogen levels. So it's almost in a way a surrogate, the elevated fibrinogen, again, showing increased inflammatory markers. Um, in the patients that had they were having reduction of IL-6 and tissue necrosis factor. What I don't know, and I certainly will take a look at this afterwards, is, are these patients that are being treated? Some of the heparins can have anti-inflammatory properties. Again, I don't know if that's a confounder in the data. So unfortunately, I'm sorry, I cannot comment on that. What about you, George? Do you have any insight into that?
No, I really don't have any additional insight into that. And but I'm going to find out afterwards, because I know those folks who are out there in Kansas working on that. So
yeah.
But anyway, here's another one from Raymond Tessie. Says, what about von Willebrand factor? Is it elevated? Is it useful?
Yep. So there is, von Willebrand factor is elevated in these patients, and it probably goes back to the whole notion that, as I said earlier, that COVID not only infects, the respiratory epithelium, the mucosal membranes lining our aerodigestive tract, or our upper airway and lower respiratory tract, but it does actually directly infect vascular endothelium through the ACE2 receptor. I'm sure a lot of us have heard about that spike protein and binding to the ACE2 receptor, and that's how it gains entry into endothelial cells. Causing damage to endothelial cells, it causes a release of the stored von Willebrand factor from the Weevil-Piloty bodies that are then that can be measured in the plasma of patients with SARS-CoV-2. Yes. Yep. Sorry, one last point though. Is it useful? Again, I think it's just another one of the laboratory tests that shows patients could have a COVID-related coagulopathy. We know in non-COVID related illnesses and non-coagulopathic illnesses, von Willebrand's is elevated sort of as an acute phase reactant as well. So again, doesn't show much specificity, but in the right setting, I think it is, and it will be elevated in the COVID coagulopathic patient. Yep.
Okay, good. Let's see, moving along. This one we partly talked about. This is from Dr. Catherine Doig at Michigan State University. Asks, what is the explanation for an increased fibrinogen in what is essentially a DIC type process?
Sure. So again, I think a lot of it is the inflammatory process. Fibrinogen is an acute phase reactant. Fibrinogen is seen in a whole host of patients that have non-COVID related coagulopathies but are in the ICU. If they're not having fulminant liver failure, if they're not having synthetic issues with the liver. So the thought process is that this is a robust inflammatory process that's resulting in elevated fibrinogen. And as pointed out earlier, the fibrinogen levels remain elevated in both survivors and non-survivors. And then in the non-survivor group, the fibrinogen does appear to drop off. Question really is what's causing this marked drop in fibrinogen? Is this now a patient that's entered into full-blown DIC, in which the DIC score requires a fibrinogen level to be low? Is this a synthetic issue in a patient with DIC or the true consumptive coagulopathy?
Okay, good, thank you. This is a pretty loaded question from Joan Plancic out in Denver. So are there recommendations to screen all hospitalized COVID patients for coagulopathy? If so, just a D-dimer to screen and then other tests if it's abnormal? I love that.
Yeah, boy. That is a pretty tough question. That is a loaded question. I think, proper utilization of laboratory tests is, I think, important. I think understanding the severity of a patient and how ill they are. So if you have a patient who is in the hospital, who is sick enough to be in the hospital, but not in the ICU, screening them for coagulopathies through regular laboratory testing. I don't know if there's literature to actually support that practice. I'm just kind of running through my head here. What I do believe is, or what I would surmise from the data though, is patients that are ill enough to be in the ICU. There has been some suggestion in the literature that those patients should be put at least on prophylactic doses of heparin, if not therapeutic levels of heparin, to prevent them developing a coagulopathy, for treating perhaps an unknown coagulopathy and preventing them from going into DIC. So to test all patients in the hospital with COVID for a coagulopathy using those laboratory values, I really think you still have to use clinical judgment and determine whether or not this patient has significant respiratory compromise, sick enough to be in the ICU, versus a milder form of the disease. I'm curious, has anybody else responded in the chat about this? That's a very good question.
Yeah, it really is. I haven't seen another answer to that. And it is interesting. The concept of screening is, a broad concept in which you're really testing people who are otherwise unselected.
Correct.
In this case, we are talking about people who, have been diagnosed with COVID. But there's a great talk that was given by Dr. Gary Prokop last week about the statistics of screening and the number of false positive results. You end up chasing your tail if you are doing too much testing.
Well, and I think that's the, again, in the second part of the question was, D-dimer, as I've already said, and as we all know, D-dimer specificity is while we are identifying it as elevated in these patients, in concert with all of the other laboratory values, particularly the fibrinogen, I think in a patient with a respiratory-like illness with a high fibrinogen and a high D-dimer, I think that really does need to raise the concern that this patient could progress, particularly if their respiratory compromise is worsening. Yes.
Yeah.
Yep.
We're running out of time. I'll have one more question I want to ask. There are some comments that I see about the TIG that are not totally complimentary. And I know that for many of us, the TIG has gained in importance and usefulness over the years, but it's been around since 1945. And for a long time, it was really more art than science, but I think that it's made some inroads. So the last one I think we have time for comes from Gordon Enns. He says, are there biomarkers that appear early on indicating activated platelets interacting with endothelial cells? You might be looking for, like, I don't know, platelet factor 4 or p-selectin.
Yeah. Those could be yes, I think that's entirely possible. I don't know if I ran across that in the literature. I mean, there were certainly some hypotheses theorizing, particularly around the PF4, around the HIT discussions as to whether or not what PF4 levels were. I will say that there was a study. It was not a peer-reviewed study that reported patients having PF4 dependent, the unfractionated PF4 dependent antibodies being identified in patients that had yet received heparin therapy. Go figure. So is it possible that you could use something along those lines to identify early activation of platelet? In theory, I guess, George, but I guess I don't fully know if that would be something that could be clinically useful at this point. I don't know. Have you run across any of that? I have not run across anything that.
I've not seen. I've seen only research applications for platelet factor 4,
correct,
and p-selectin, and there is a urinary 11-dehydrothromboxane test that's useful.
Right.
And, I don't see those as being acute tests that you can use, though.
No, certainly not. And that p-selectin is one of the newer ones that's being used. One of the platelet function activation assays that's being used for HIT. It's one of the complements to the SRA that we're also familiar with, the serotonin release assay.
Oh yeah. Oh, that's interesting. Good.
Yep.
Well, we have more questions, but I think we have run out of time. So I think what I'd like to do, if it's possible, conserve the questions and answer them in writing, and then make them available to people afterwards. I hope that's possible. Our hosts can tell me if we can do that or not. But anyway, I do want to thank Dr. Goodwin very much for the presentation that we've had, and thank everybody for hosting this. And I believe at this time it would be appropriate to turn it back over to Rose to summarize.
Thank you. Yes, I want to thank you, Mr. Fritzma, and Dr. Goodwin for that engaging dialogue about one of the most critical issues in the management of people with severe illness due to COVID-19. We hope you can all leave the webinar tonight with a greater knowledge of the pathophysiology of COVID-19 associated coagulopathy and its alignment with lab results and patient outcomes. This webinar was supported by an educational grant from Biomedica Diagnostics, Inc., a member of the Scotia Investments family of companies. On behalf of the sponsor and our speakers, thank you for attending this important webinar, and good night.